Now coming to the canalicular stage, which spans from 16th week to the 26th week of intrauterine life, wherein it ends by the formation of respiratory bronchioles. So there are about 3 generations of branching that can happen in the canalicular stage, where with these generations of divisions, the terminal respiratory bronchioles will amount to about 2,60,000 of them that are being formed by the end of the canalicular stage, where there is increase in capillaries also that is seen along with the bronchial tree division, and they come in close contact with the distal air spaces, because this is the respiratory bronchioles. So they try to come into the close contact where they are forming the primordium of the alveoli. So even the cuboidal epithelium will begin to differentiate as simple squamous epithelium for this in these primordial alveoli that are going to be formed, and the simple squamous epithelium will be forming into type 1 pneumocytes, and the cuboidal cells that remain as they are will be forming type 2 pneumocytes. And these type 2 pneumocytes act as stem cells to whole of the alveolar epithelium, and they secrete this surfactant which is very necessary for the viability of the fetus. And as the differentiation of the respiratory bronchus to the primordial alveoli takes place, there is approximation of the blood capillaries too, and there is formation of alveolar type 1 and type 2 cells, and there is secretion of surfactant which line the alveoli, preventing its collapse. So the fetus, if born at the end of this stage, that is at the end of 6th month or the commencement of the 7th month, there is all chances of the fetus to survive, the born baby to survive, by administering the external corticosteroids to increase the surfactant secretion by type 2 cells, and to give a high-end intensive care even after the birth for about a couple of months to come for the survival of the baby. And still the baby may not survive because all the other systems are in the process of development. Next, coming to the saccular stage, which spans from week 24 to the week 40. During this stage, the terminal sacs are formed from the respiratory bronchioles, and the alveolar ducts are also formed. That is the reason, as the alveolar sacs are formed, it is called as saccular stage, and as the terminal sacs of the alveoli are also formed, it is also called as terminal sac stage. So here in this stage, the formed alveolar sacs, they lengthen and widen, giving outpocketings of the alveoli. So the primordial alveoli which are present in the previous stage, the canalicular stage, now become and differentiate as the alveoli. And the fibroblasts that are present in the mesenchyme, they differentiate to form fibroblasts, and they produce extra matrix. That is, the elastic fibers and the reticular fibers surrounding the alveolar sacs and the further divisions, that is the alveolar ducts, alveolar sacs and the alveoli. Even there is further division of the vascular tree that happens, and they indent on to the developing alveolar sacs. They bulge so that the epithelium between the capillary and the alveoli, they approximate each other so much that both basement membranes join or fuse to form a single basement membrane that will be shared between the endothelium and the type 1 alveolar cells, which makes it possible for the gaseous exchange. And the cuboidal cells which are left like that, they develop as type 2 pneumocytes or type 2 alveolar cells, which secrete surfactant, which is very, very important to decrease the surface tension of the alveoli, preventing its collapse during the expiration, which is called as atelectasis. The collapse of alveoli is called as atelectasis. So that is being taken care by the surfactant that is produced by type 2 cells, and that line the interior of the alveolar sacs and the alveoli. So the fetus that is born at this stage can survive because there is gaseous exchange that is being established, can get established after the birth because there is no respiration as such that is happening within the fetus. So there is a possibility of the gaseous exchange that can happen has been created, and the surfactant is being secreted by the type 2 cells. Next stage is the alveolar stage, which is between the 36th week to 8 years of age. So if you have observed, there is overlap of these weeks on to the previous stages. So the main characteristic feature of this stage is the development of definitive alveoli, and more so is the formation of secondary septa. So the secondary septation occurs, which means that interalveolar septa are formed within the alveolar sacs, dividing them into number of alveoli. So there is a significant increase in the number of alveoli that are formed, along with the number of capillaries that are surrounding the alveolus is also increased, and the surfactant amount that is secreted is also sufficiently increased, which can make the born baby very much viable. So by the end of the late fetal period, that is just before birth, the lungs are capable of respiration because alveocapillary membrane is sufficiently become thin, which can allow a proper gaseous exchange between the capillaries and the alveoli. So although the lungs, which do not begin to perform its main function, the respiration, until birth, they are well developed so that they are capable of functioning their main function, that is the respiration, as soon as the baby is born. So the transition from dependence on the placenta for gaseous exchange to the regular gaseous exchange that happens in the lungs requires few adaptive changes in the lung. First and foremost being the sufficient production of surfactant within the alveolar sacs, and transformation of lungs from secretory into gas exchanging organs. That will happen from the time of birth. And establishment of parallel pulmonary and the systemic circulations, that is the bronchial and the pulmonary circulations. So the characteristic mature alveoli do not form until after birth. So the 95% of mature alveoli, they develop postnatally, that is after birth. So the alveolar development is largely completed by 3 years of age, but new alveoli are added until about 8 years of life. That is because of the secondary septation that is occurring within the alveolar sacs. So there is constant formation of interalveolar septa within the alveolar sacs, forming plenty number of alveoli around the alveolar sac, along with the division of the capillaries surrounding each alveolus for sufficient gaseous exchange. So by this process, there is an exponential increase in the surface area of the blood-air barrier through the multiplication of alveoli and capillaries around the alveoli. So around about 150 million alveoli are present in the lungs of a full-term newborn infant. As the addition or the multiplication of the bronchial tree that extends till about 8 years of age, which will divide and accommodate another 150 million, which comes to about 350 to 400 million of alveoli, which are the adult number by the end of 8 to 10 years of age. So after birth, the first cry of the baby is going to transform the secreting alveoli into the gaseous exchanging alveoli, because at birth the lungs are almost filled with fluid that is derived by the amniotic cavity, that is the amniotic fluid that enters into the lungs and the airway and the secretions from the lungs and the secretions from the tracheal glands. And with the first cry of the baby, the fluid in the lungs is quickly cleared by 3 routes. Number 1 is during the vaginal delivery, that is the normal delivery. There is compression of the thorax that happens during the baby's delivery from the uterus outside. So most of the fluid is expelled through mouth and nose by pressure on the fetal thorax. Then most of the fluid is also absorbed by the pulmonary arteries, veins and capillaries, and also into the lymphatics that are surrounding the bronchial tree. That's how quickly the fluid that is being filled within the alveolar sac and the alveoli and the whole of the tracheobronchial tree is being absorbed, and a gaseous exchanging atmosphere is being created where it makes lung into a space that is filled with air. So to the near-term fetus, that is at the end of the gestation age, the lymphatic vessels are relatively large and more in number than in an adult. So this lymph flow is very rapid during the first few hours after birth because they have to absorb all the fluid that is being present in the bronchial tree, and then it diminishes. So the three factors that are very important for the normal lung development are the adequate thoracic space for the lung growth, because the lung has to grow laterally, posteriorly, anteriorly, caudally, and cranially as well, and fetal breath movements and adequate amniotic fluid volume. So this is the diagrammatic representation representing all the stages of the formation of the bronchial tree, wherein during the embryonic stage, it is the formation till about the tertiary bronchi, and pseudoglandular stage, it ends by the formation of terminal bronchioles. In the canalicular stage, the respiratory bronchioles are formed, wherein you can very clearly see the outpocketings of the alveoli from the respiratory bronchiole. The saccular stage represents the alveolar sacs, outpocketings of the alveoli over that. And there is proper secretion of the surfactant also seen. And the alveolar stage, where there is formation of the mature alveoli, which spans through the postnatal life till about 8 years of life, where the total number of the alveoli are formed due to the secondary septations, which mean that interalveolar septa are formed, which will instigate the multiplication of the alveoli from the alveolar sacs. So there is very clearly, you can see the overlapping of all the stages. So there is not that it ends here and then it starts. There is an overlapping of all these stages, and accordingly to the division of the bronchial tree, there is formation of the blood vascular system as well, where the pulmonary artery will be dividing successively into minute divisions, where the capillaries are encircling the formed alveoli for the gaseous exchange through the process of vasculogenesis followed by angiogenesis, and then the pulmonary vein that is being formed and is drained into the right atrium, the left atrium, wherein there is sudden increase in the pressure of the left atrium, wherein the fossa ovalis is closed. So the foramen ovale is closed. So from the right atrium, the blood flows to the right ventricle, then through the pulmonary artery to the lungs. And from the lungs, via the pulmonary vein, it comes to the left heart, left ventricle, aorta into the systemic circulation. So that's how the few changes also occur from fetal circulation, establishing the adult circulation by birth. So that we will see in detail in the cardiovascular development. So coming to the histogenesis, as we have seen, the respiratory epithelium which is there in the bronchi slowly will be transforming from the ciliated cells to the simple columnar, then to the simple cuboidal cells, intermingling with the Clara cells. And as they come on to the alveoli level, most of the cuboidal cells are transformed into simple squamous type 1 alveolar cells, which are responsible for the gaseous exchange. And the cells, few of them, are cuboidal in shape, that are left without any morphological change. They transform into alveolar type 2 cells, which secrete the surfactant that will be lining the interior of the alveoli. And in the connective tissue, the mesenchymal cells differentiate into fibroblasts, which are responsible for secondary septation and the secretion of the elastic reticular and collagen fibers that are present within the interalveolar septum. So coming to the surfactant proteins, there are about 4 types, type A, B, C, and D. So type A, what happens is this type A surfactant will enter into the amniotic fluid and acts on macrophages in the amniotic cavity, stimulate them and cause the migration of macrophages across the chorion into the uterus, where they begin to stimulate increased production of prostaglandins, which in turn cause the contractions of the uterus when the fetus is at term. And surfactant B, C, D all contribute for the main purpose of having the surfactant within the alveolar cavity to reduce the surface tension and prevent the collapse of the alveoli during expiration, and also have an immune response. Before coming to the applied aspect, a small note on the breathing movements of the lung before birth. So these fetal breathing movements, which begin much before birth, are responsible for aspiration of the amniotic fluid inside, which is also necessary for the development of the branching pattern of the bronchial tree. These fetal breathing movements, they are very important for stimulating the lung development and conditioning the respiratory muscles for their function after birth. Since the respiratory muscles become conditioned by these fetal breathing movements, after the birth, after the ingestion of air into the lung, there is a proper rhythmic respiration that is being accustomed and developed by these respiratory muscles as these fetal breathing movements, which become more and more severe during the end stages of gestation, which is responsible for tuning the respiratory muscles to be functioning after birth. So agenesis of lung, that is, there is no formation of lung on one side. Here you can see in this picture, the left lung is present, but the right lung is not present. In this, the right lung is present, but the left lung is not present. So there is no development of the lung. This agenesis can be unilateral or bilateral. Bilateral is very, very rare, and the person may not live also. The baby cannot survive after birth. So the unilateral agenesis is compatible with life to a certain extent, wherein the other structures of the mediastinum are all pushed onto the affected side. So the heart is being pushed and the posterior mediastinal structures are all pushed onto the affected side, and there is hyper expansion of the lung that has been developed. So this hyper expansion of the lung will compensate a bit for the agenesis of the other side of the lung. So this is the live structure where there is no division of the trachea onto the right side. There is no primary bronchus on the right side, and that is the reason there is no formation of the right lung as well here. And you can see the heart and other structures that are shifted onto the right side because of the absence of the right lung. Coming to the lung hypoplasia, that is because of the decrease in the formation of the lung of that side. They're usually unilateral, and that is mainly because of the diaphragmatic hernia, that is the congenital diaphragmatic hernia, where the abdominal contents will enter into the thoracic cavity of that side and not permitting the expansion of the lung of that side. So there is decrease in the development of the lung on the affected side where there is diaphragmatic hernia that is seen. So this lung hypoplasia markedly reduces the lung volume, and there is hypertrophy of the smooth muscle in the pulmonary arteries that is seen. So normal flow is also hampered, which will lead to pulmonary hypertension. Because of this, the ductus arteriosus will be patent even after birth. So there can be this congenital lung cyst also can be seen, where there is dilatation of the terminal bronchi that are seen, and that is because they enlarge more than its capacity. So they appear as the congenital lung cyst, which can be made very clearly on the radiographs. So this is how the congenital lung cyst will be seen, because of the hyperextension of the terminal bronchi divisions, that is at the level of the canalicular stage. And there is another condition called as bronchopulmonary sequestration. Sequestration means a separated structure. So this is a very rare condition wherein there is an appearance of the lung tissue which is not functioning and is not attached to the routine bronchopulmonary tree divisions. So there is no communication between this bronchial tree and this extra structure, the separated structure that it develops. So it has a stump. The nutrition to it comes from the abdominal aorta, and there is no function of aeration or anything for this part of the sequestered lung tissue. So, but it is viable because of the blood supply that it receives from the abdominal aorta. So this is totally a non-functional mass of the lung that is seen, which is not developed from the routine branching of the bronchopulmonary tree. So the another condition is lung hernia, which is also called as Simpson's hernia, where it is more common towards the apex of the lung, but can be seen in the other parts of the lung because of the injury to the thoracic wall, where the protrusion of the lung is seen between the intercostal spaces, and 20% of these cases are congenital. That is because of the lack of development of proper tone to the respiratory muscles, that is the intercostal muscles. And most often they are seen in the chest trauma or thoracic surgery or any of these pulmonary diseases where the alveoli lose their contour, like in emphysema and all that, because that tension of the alveoli is lost. And these are all treated surgically by removing this part of the lung and bracing this part of the intercostal space by wires, so that the intercostal muscles are not, because they already have lost the tone, so by bracing them they retain that stiffness and pressure that is exerted by the lungs during respiration. And another one is the respiratory distress syndrome of newborn, which is mainly because of the insufficient production of the surfactant by type 2 alveolar cells, which is also called as hyaline membrane disease. That is because as the surfactant lines the alveoli, the surface tension is being maintained during the respiration. So when there is decrease in the surfactant production and the surfactant not being lining the alveoli surfaces, there is collapse that can be seen with the alveoli during expiration, which is called as atelectasis. So this will decrease with the advance of the gestational age, because the surfactant production is more towards the end of the gestational age. So this sort of a condition, the respiratory distress syndrome or the hyaline membrane syndrome, is seen more so in premature babies who are born at end of the 6th month or the beginning of the 7th month, because there is insufficient production of surfactant by type 2 cells, and there is artificial induction of the surfactant production by giving corticosteroids to the baby and to the mother before delivery. And this is less seen at the full-term babies who are born because of the proper sufficient secretion of the surfactant amount that is required to maintain the elastic recoil of the alveoli during the respiration. So this is what is all about, and this is another one which I like, so I wanted to share with you. Education begins the gentleman, but reading, good company, and reflection must finish him. So your way of behavior has a very big impact on your character and yourself being a professional in your career. Thank you.